We are live.
Okay. So, good evening, postgraduates, and welcome to this 101st episode of All India Postgraduate Teaching Program, which is an initiative from ARC, All India Ophthalmological Society. We call this PG program a program with difference because it covers the uncovered aspects of teaching, like case presentation, journal clubs, OSCEs, and rarely didactics on topics which are not comprehensively available for you in a textbook. So, today is the 101st episode. Today, we will be having two short cases. The first case would be presented by Dr. Nikita Balani, who is a second year resident at Drashti Netralaya, Dahod. And the second case will be presented by Dr. Shravani, who is a final year resident at SV Medical College, Tirupati. My special thank goes to mentor Dr. Mehul Shah, who is a director at Drashti Netralaya, Dahod, and Dr. P.S. Chalapati Reddy, who is head of the Department of Ophthalmology at SV Medical College, Tirupati, for mentoring their students both. Of course, my special thanks goes to the examiner, Dr. Shrikant Deshpande, who is a professor at Terna Medical College, Navi Mumbai, Dr. T. Ravindran, who is a director, CQ and research at Sankar Foundation Eye Hospital, Visakhapatnam, and Dr. Nilima Mehrotra, who is Dean Academics, MBBS, professor and head at SRMS Institute of Medical Sciences, Bareilly. And I'm thankful to all the examiners for consenting to be an examiner. Now, without much ado, can I request Dr. Nikita Balani to share her screen, and we are ready to go. So once more,
Thank you, Dr. Prashant, for your kind words.
Thank you, sir. Thank you. So, Nikita, you can share. And as I said, all the examiners can stop or interrupt the students whenever and whatever they want for the exams and necessary information or questioning them.
Let's go. Thank you.
Make it a full screen. Yeah, fine. Nikita, best of luck. You're doing well.
Thank you, sir. Good evening, everyone. I'm Nikita Balani, a second-year resident at Drashti Netralaya, Dahod. Today, I'll be presenting a short case on subluxated cataract under the guidance of Dr. Mehul Shah, sir. A 60-year-old female resident of Dahod, farmer by occupation, presented to us with complaints of diminution of vision in her left eye for the past 6 months. The diminution of vision was since the last 6 months. It was gradual in onset, progressive, painless, with further decreased vision since the last 3 months. There was alleged history of blunt trauma by a wooden stick to her left forehead while working on the farm 1 year ago. She complained of immediate symptoms of redness and watering and abrasions over her forehead that resolved on using unknown drops and ointment. There was no history of diminution of vision immediately after the trauma, no history of ocular pain or photophobia, no history of floaters, field effects, flashes of light seen, no history of any previous ocular surgeries. There was no history of headache or diplopia or nausea or vomiting. No history of hypermobile joints or skin laxity could be elicited, and there was no history of similar complaints in the past. The personal and family history were not significant. No history of similar ocular complaints in any other family members could be elicited. Coming to the systemic examination, all the systems were within normal limits and no features suggestive of any systemic anomalies were seen. The ocular examination, the best corrected visual acuity in the right eye was 6/9 with a refraction of plus 0.5 diopters sphere under tropicamide. The visual acuity was 1/60 in the left eye, which was not improving. The left eye was not refractable due to poor glow. There was no limitation of extraocular movements in both the eyes. The intraocular pressure measured using Sheard stonometer was normal. The IOP was normal in both the eyes. On gross examination, we could see old healed abrasions over the eyebrow near the globular region in the left eye, around the left eye. On slit lamp examination, the right eye was within normal limits. In the left eye, lid adnexa were normal. The conjunctiva and cornea were clear. The anterior chamber was irregular, becoming deep in the superonasal region with a Van Herrick grading of 4. We could see vitreous mixed with iris pigments in the superonasal quadrant. The iris was brown and radial. Iridodonesis could be appreciated on eye movement. There was no visible sphincter tear. The pupil was 3 mm, round, regular, reacting to light, and there was no aphakic zone visible in the undilated pupil. It was pharmacologically dilated to 7 mm with direct and consensual reflex present. On gonioscopy, both the angles were open. No angle recession or pigment dispersion was seen. Coming to the lens, the right eye had a nuclear sclerosis of grade 1 and an early cortical cataract, while in the left eye, we could see phacodonesis, inferotemporally subluxated cataractus lens with an aphakic gap visible from 7 to 1 o'clock, that is 6 clock hours. This is the diagrammatic representation. So as we can see, the anterior segment picture of the left eye taken in the sitting position shows an inferotemporally subluxated cataractus lens and an increased red glow from 7 o'clock to 1 o'clock, which is the aphakic gap. No zonules are visible in that area. The posterior segment examination was normal for the right eye, while for the left eye, we could only appreciate the glow in the aphakic area and the visible retina was attached. Rest of the details could not be appreciated because of a cataractus lens. The following investigations were done. Axial length was almost equal in both eyes. These are the keratometry findings. The anterior chamber depth was 3.68 mm in the left eye, which corresponds to our finding of an increased deep anterior chamber, as opposed to that of 2.88 mm in the right eye. This is the B scan of the patient, done in sitting position of the left eye in vitreous mode. We can see a moderately high reflective structure in the anterior vitreous, which corresponds to the subluxated crystalline lens. The rest of the vitreous cavity appeared echo-free, and the retinochoroidal scleral complex showed high reflectivity, suggesting an attached retina. So with our clinical findings and the investigations done, we conclude to the diagnosis of a left eye post-traumatic inferotemporally subluxated cataractus lens with a zonular dialysis of 6 clock hours. According to the Birmingham eye trauma terminology, this comes under the category of a closed globe injury with the subtype of contusion. The ocular trauma score of the patient was 3. Based on the degree of subluxation of the lens, here are the surgical management strategies that can be utilized.
I think we can have the examiners before we go to Dr. Nilima ma'am, Dr. Ravindran sir, you can now go ahead with the, or you want the whole examination, strategy to be told first?
I think first the strategy can be discussed, told. Yeah.
Okay. Go ahead, Nikita.
So, sir, these are the strategies that are available to us. But out of this, what we did in this particular case was an intracapsular cataract extraction with a scleral fixated IOL. Here are a few stills from the surgery that was done. It was performed in 2 settings. Firstly, we did the cataract extraction with the back. And on a later date, in the second sitting, we did a scleral fixated IOL. This is the post-operative outcome, sir. On the first day follow-up, this is the first image. And at 1 month follow-up, the patient had a best corrected visual acuity of 6/12 parts with a refraction of -3 diopter cylinder at 95 degrees. Thank you.
All right, Dr. Nikita, nicely presented. So you said...
Can unshare the screen, Nikita, once? Yeah.
Stop sharing.
Yeah.
So you said that the zonular dehiscence was from 7 o'clock to how much was it? Sorry.
1 o'clock, ma'am. 7 to 1. About 6 clock hours in the sitting position.
All right. But yet you decided to go in for ICCE and SFIOL.
Yes, ma'am. So intraoperatively, the degree of zonular dehiscence noted was more. And even when we made the patient lie down on supine position, the lens was slightly posteriorly subluxating. So the degree of ZD was more than what we could appreciate on slit lamp.
All right. So intraoperatively, you felt that the zonular dehiscence was more. How did you fix your scleral SFIO?
Ma'am,
Suture or non-sutured?
non-sutured, ma'am. This is a sutureless, glueless technique. The lens has two flippers and two scleral pockets are made, and the flippers are tucked into the scleral pockets. So it does not have the disadvantages of the suture degrading.
All right, wonderful. And what experience do you have with capsular tension rings to be used in such a case? What
Ma'am,
would you have preferred, I mean to ask?
yes,
If you
ma'am.
decide to go in for a extracapsular extraction and in the bag IOL?
Yes, ma'am. Ma'am, we have various capsular stabilization devices available. So depending again on the degree of the zonular dehiscence, if it is less than 4 clock hours, up to 25%, we can insert a capsular tension ring and do an in the bag implantation. If it is about
All right. When would you like to insert this ring? If you use a CTR, at what point in the surgery would you like to insert it?
it can be inserted at various points. That is before the capsulorhexis. If we are having a difficulty in performing the
What
capsulorhexis,
capsulorhexis?
ma'am, we can use a capsular hook. And ma'am, after the capsulorhexis is done, we can insert the capsular tension ring. That is before cortex aspiration.
Because I don't know where you would insert it when you
So, ma'am,
make a
I'm
capsulorhexis.
sorry.
Would you have any modifications in the or any special precautions while making the capsulorhexis in a patient with a subluxated cataractus lens?
Yes, ma'am. We have to start from the point where there is good zonular support. We should not start from where the zonules are already weak. And even if the bag is subluxated, we must try to keep our rhexis centered to the bag and not the pupillary area. And as I was trying to say, ma'am, we can use capsular hooks for support if we do not have enough.
Iris hooks can be used to support the capsular bag, right? CTR is preferred mostly.
Dr. Ravindran, sir, your questions?
So, what are the other options apart from CTR? Suppose the zonular dialysis is more, what would you be using?
So we could use a modified CTR like a Sionis ring, which has an eyelet. So we can fixate the bag to the sclera using the eyelet. And we also have capsular tension segments like the Emmett segment. A single or double segment can be used in the region of the zonular dehiscence, and we can fixate the bag to the sclera again with the eyelet of the.
Very good, very good. Then you did the surgery in 2 sittings. What were the specific reasons in this particular case? Would there be any option of single sitting?
Yes, sir, there could be a single sitting.
So what are the indications when you would prefer to do it as a 2 sitting versus 1 sitting? That is what sir is asking.
Sir, if there is increased manipulation in the first sitting, we would want to defer the second surgery, the second procedure to another sitting. And we can also wait for the inflammation to subside.
Wound stability is something that you would think of?
Yes, sir.
So that the retina surgeon or the anterior segment surgeon, whoever is doing, is having a better exposure
Yes.
there.
Yes, sir.
So this was a SICS mode surgery or a phaco mode surgery initially?
SICS mode surgery.
SICS mode. So a scleral tunnel from a head end or 12 o'clock meridian or
12 o'clock meridian.
12 o'clock meridian. And you have already prepared the patient up for 2 sittings initially.
Yes, sir.
Is that so? Or
Yes.
you took a decision during the surgery that you'll go from single sitting to two sitting?
I think we had already prepared the patient.
You are already prepared. Yeah, okay.
I'm interested in the mode of delivery of lens. How did you deliver? Which instrument did you use?
So a Vectis was used to deliver the lens. So initially, because yes, sir, there was already a vitreous in the anterior chamber, so we
Okay.
had performed anterior vitrectomy. Following that, the nucleus along with the bag was delivered using a wire Vectis.
Did you stain the antivitreous or you didn't stain?
No, sir, not in this.
Okay. What retinal complication do you expect in such patients? Or macular complications rather?
Sir, if there is traction caused to the vitreous, it could lead to a retinal detachment later on.
More commoner than that. Will you expect more incidence of cystoid macular edema?
Yes, sir.
So, did you alter your post-operative regimen for that or use your normal regimen?
So systemic steroids were also given.
You did use systemic steroids?
Protocol to have systemic steroid, right?
Yes, sir.
And speak.
Yes, sir.
Did you suture the wound?
Yes, sir. The wound was sutured.
Why should we suture even if it is self-sealing
Sir,
in such patients?
we are anticipating another surgery, and we will we will be making ports. So
Something like scleral collapse, rigidity.
Scleral rigidity.
Yes. It alters the anatomy of the eye. Vitrectomy. Was retinal surgeon present or in the loop when you took the patient, or retinal surgeon only did this case?
yes, sir.
Her mentor is a retina surgeon.
Then there
Oh,
is no
yes.
problem.
Actually, she mentioned ICC. We did the cataract vitrectomy.
Oh,
And
Achha.
the lens which we have designed, that scleral tuck lens that we have used without suture and without glue.
Oh.
That is
So
great.
what was the grade of the cataract, sir?
I think
Was it
NS4
hard?
full. It was hard cataract.
Oh.
That's the reason we have taken this loop. Otherwise, we'll drop the nucleus in and then use the fragmentome.
Yes.
I'm interested in how you did the anti-vitrectomy. Was it a closed chamber technique or something else?
Closed chamber technique, where I
Yeah.
think we have seen that I used the AC maintainer and did the anterior vitrectomy, which vitreous was prolapsing, and then made the nucleus free so that we don't pose any traction on the peripheral vitreous.
So here the cutting rate and aspiration rate and flow will be important.
It is a
Hmm.
Venturi base, so there is no flow rate.
Yeah.
Also, Dr. Nikita, I noticed your patient had a lot of post-operative astigmatism. You mentioned the keratometry readings earlier and then post-operative astigmatism. What are you going to do about it? Is she here?
Yeah, she's there.
Yes, ma'am.
How long have you followed this patient post-operatively?
I
I
have.
don't think you mentioned the dates of when the patient presented to you or when you operated in your case presentation.
Yes, ma'am.
Mm.
The data I have, ma'am, with me is from the 1 month post-op follow-up.
You have followed up for 1 month now.
Yes, ma'am.
So what do you intend to do about the astigmatism which has been induced by the cataract surgery? And why do you think it happened at all?
Because of the sutures that were taken.
What type of sutures did you give?
10-0 continuous suturing of the wound.
So you gave a 10-0. You said you started with a manual SICS incision, right?
Yes, ma'am.
So, what was the shape of your incision? Round shaped or straight or something else?
Round shape incision.
Okay, and then you still gave continuous 10-0
Yes, ma'am.
sutures. So, for continuous sutures and post-operative astigmatism, what will you do and when will you do it? Or will you do anything at all?
We can do a suture removal at a later date.
What date?
2 to 3 months after the surgery.
Nikita, can you tell what are the various techniques which you will employ while doing cataract surgery to minimize astigmatism? That is what Dr. Nilima ma'am is trying to reach you out at, asking you. Various strategies rather.
Actually, I also want you to elaborate what do you think, why the astigmatism is? Is it because of suture or it is because of lenticular astigmatism? Then I'll answer.
Both the components, sir.
It is a lenticular astigmatism because of scleral fixated lens rather than corneal astigmatism.
Yes. So in cataract surgery, ma'am,
How will you find out whether it is lenticular or corneal plane?
ma'am, the keratometry readings will tell us.
Did you do it post-operatively? You already followed for 1 month.
Yes, ma'am. I do not have the 1 month keratometry readings, ma'am.
All right. And you said you'd like to remove sutures after 2 to 3 months. Is that all right?
No, ma'am. Usually we don't do it unless a knot is exposed or if it is causing irritation to the patient. Only then we go ahead with it.
You won't have any exposed knots in continuous suturing, will you?
No, ma'am.
So you will remove it if you think the astigmatism is due to tight sutures or
Due to tight sutures.
So what is the ideal time if it is a corneal wound, if it is a scleral wound, how early can you remove it? Nikita, you can answer it to the examiners that way.
Okay.
So why there is a difference between corneal and scleral wound and regarding the healing process? I'm giving you a hint.
So the healing time is different. For the corneal wounds, it is about 21 days.
What about scleral?
I'm not sure. Sir.
Sooner or later?
Later.
Cornea is a avascular structure, correct? So, and sclera is a vascular structure. The healing will happen more faster with sclera. So, corneal wound can be, do not heal, they are approximated. So, you have to delay it and look for the thing. So, so if it is more corneal wound, you would like to remove it more later. Okay, that should be your answer, something like this. Deshpande sir, few more questions. We have another few minutes, 5 minutes for her.
Yes. What are the late complications that you might expect in this patient? Means what will you follow the patient for? It's not a routine cataract surgery now. So in post-op visits, what will you look? I mean, after delayed, after 2 months or some.
So since this was a post-traumatic case, we will have to follow up the patient for secondary glaucoma, which can be post-trauma.
Things.
So you'll check the pressure, right?
Yes, sir.
Gonioscopy?
Yeah, I was also wondering, did you do gonioscopy preoperatively?
Yes, sir. Gonioscopy was done.
What did you find?
Sir, we found open angles and we did not find any other signs of trauma like an angle recession or pigment dispersion or tears of the trabecular meshwork or iris processes.
Okay. Apart from trauma, what is the, common cause for this subluxation or weak zonules in elderly patients?
So in elderly patients, there could be acquired causes like pseudoexfoliation syndrome, or there could be a hypermature cataract leading to zonular weakness. There could also be other systemic causes, but they will not present later on in life. They will present sooner in life, like syndromes, Marfan syndrome or Weil-Marchesani or homocystinuria, but they will present earlier.
Sir, why didn't you consider iris fixated lens in these patients? Pupil was round, na? Was
Yes,
that in?
Traditional.
yes, sir. It is.
निकेतन हवा अर्जेस रिक्वायर्ड टू काही बोलती this.
So you should answer, Nikita, what are the cases, indications for iris fixated lenses versus scleral fixated lenses? Indications, contraindications, or complications. Answer like that. Yeah.
So, sir, iris fixated lenses can be anteriorly fixated or posteriorly. We prefer posteriorly fixated lenses, iris claw lenses. A regular round pupil with no signs of glaucoma and good AC depth, we can go with an iris fixated lens, while we can also go with scleral fixated lenses when we do not have enough iris tissue. If there is a irregular pupil and iridia. Sir, for iris fixated lenses, for scleral fixated lenses, patients with there is no scleral rigidity, proper rigidity, then that would be a contraindication.
Zones of injury will be important.
Yes, sir, zones of injury will be important. If it is a zone 1, if in open globe injury, zone 2 and 3, then we cannot go with scleral fixation.
So how will be the pupillary dilatation after iris fixated lenses? Will it be adequate enough for posterior visualization when you have a traumatic cataract? And a follow-up you said about. So that is why you did a scleral fixation where you have a better size of a pupil. You will have a better visualization because just putting the lens is not important. Future follow-up, anticipating the long-term complications of trauma. That is the reason how you should justify it.
And sir was asking about the post-operative possible complication. That was a retinal dialysis. That's what you did not speak.
Correct. Very well said. So I think Ravindran sir, Deshpande sir, and Nilima ma'am, any more questions for Nikita? Or shall we move to next case?
No, I just have a small suggestion which I give to most of the residents.
Please, please.
Keep your slides not too crowded with text. You can just put small and know your thing. You should know. You don't have to read it out from the slides. Don't put everything on your slide.
Yes, ma'am.
Yes, ma'am.
There's a rule of 6. Not more than 6 words per line, not more than 6 lines per slide. Okay, you can make it 5 also.
Correct.
Not more.
So thank you. Thank you.
Nicely done.
Thank you all.
Thank you. Thank you, Nikita. You presented well and you passed with a flying colors with all the examiners and that to an online exam. So a big round of applause for you as well. Good. Very well presented. And of course, thank you, Dr. Mehul Shah, for mentoring her. Now let's move on to the next case, and it is going to be by Dr. Shravani, who is a resident at Department of Ophthalmology, SV Medical College, and it is mentored by my dear friend Dr. P.S. Chalapati Reddy from Tirupati. So Shravani, you please share your screen.
Good evening, one and all. Myself, Dr. Shravani, and I'm from SV Medical College, Tirupati, and I'll be presenting a short case on unilateral aphakia under guidance of Dr. P.A.S. Chalpati Reddy sir, head of the Department of Ophthalmology, SV Medical College, Tirupati. So this is a 52-year-old male patient who is a resident of Adoni in Andhra Pradesh and employed as a heavy vehicle driver with poor socioeconomic status, presented with chief complaints of diminished vision in both eyes, which was noticed for past 1 year in right eye and for past 6 months in left eye. So the patient presented to our OPD in June 2025 with a history of diminution of vision for both near and far distance, which was noticed in right eye for past 1 year, which was insidious in onset, painless, and gradually progressing in nature. He consulted at a local hospital and was advised for cataract surgery, and he underwent surgery in November 2024, following which he noticed worsening of symptoms in right eye. There's a history of diminished vision in left eye, which was noticed for past 6 months, which is of insidious onset, painless, and gradually progressing in nature for both near and far distance. There's no history of diurnal variation. There's no history of double vision, no history of usage of spectacles. There's no history of intolerance to light, no history of colored halos. There's no history of flashes and floaters, no history of distortion of image. This patient is a known case of hypertension and diabetes for past 1 year on irregular medication. So he's on amlodipine 5 milligram once a day and metformin 500 milligram twice a day. On talking about past illness, there was no history of tuberculosis, bronchial asthma, coronary artery disease, and cerebrovascular accidents. Personal history, he takes a mixed diet, his sleep and appetite are normal, bowel and bladder habits are normal. There's no history of smoking or alcohol consumption, and there's no history of drug allergies. And family history is not significant. On general examination, this patient is of moderate build and nourishment. He is conscious and cooperative, with no evidence of pallor, icterus, cyanosis, clubbing, pedal edema, and lymphadenopathy. On examination, his pulse rate was 78 beats per minute and regular. BP was slightly on a higher end of the systolic with 146 and 90 mmHg in right upper arm in sitting position. His respiratory rate is 88 per minute and temperature afebrile. So coming to the summary, this is a patient of 52-year-old with complaints of gradual painless progressive diminished vision in both eyes for past 1 year in right eye and for past 6 months in left eye. And there is a history of cataract surgery, which was done elsewhere 6 months back. And patient is a known case of hypertension and diabetes on medication for past 1 year. On local examination, the head is straight, face symmetrical, chin upright, and alignment of eyes orthophoric. On examination, the patient's visual acuity in right eye is 1/60 with pinhole 624, and near vision is N36. The best corrected visual acuity came to 624 parts with +12 diopter spherical, and near vision is N12 parts with +3 diopter spherical. Eyebrow, eyelids, eyelashes were normal, and palpebral aperture horizontal was 28 mm and vertical 9 mm. Conjunctiva, palpebral conjunctiva was pink, bulbar muddy. On examination of sclera, a faint superior temporal scleral scar was noticed 3 mm away from the limbus. The cornea, the size, shape, surface was normal, except for the transparency, where at 5 o'clock position there was iris pigment present over the endothelial surface. The sensations were intact. This is the picture showing the same. It's marked, but the scar was very faint, and you can see the endothelial deposit on the pigment deposit on the endothelial surface. On examination of the anterior chamber, the depth was peripheral anterior chamber depth is 1 PCT, that is indicates deep, VH grade 4, and vitreous condensation bands were noticed at 7 o'clock to 12 o'clock. Iris color brown, pattern wavy with iridodonesis. On examination of pupil, color was jet black, size 2.5 mm into 2 mm, shape irregular, and peaking noticed at 10 o'clock. Vitreous adhesions noticed from 7 o'clock to 10 o'clock. Posterior synechiae with capsule and vitreous condensation bands noticed at 7 o'clock, and with sluggish pupillary reactions. On examination of lens was absent with vitreous stance. Extraocular movements full and free in all gazes. So we can see the vitreous strands in the pupillary area with condensation and peaking at 10 o'clock position, and the color of the pupil as well. The left side is the right eye and the right side is the left eye. We can see the grading as well. Coming to the left eye, pretty much normal. Left eye vision is 5/60 with pinhole improving to 624. Neo vision N12. 624 parts. The best corrected visual acuity is 624 parts with -3 diopter spherical. Eyebrow, eyelids, eyelashes were normal, and palpebral aperture is 28 mm and 9 mm. The conjunctiva, palpebral part pink, bulbar muddy, sclera was normal, cornea was normal, and PACT is half PCT with the clear contents, iris brown and wavy. The pupil size was 3 mm and round, reactive. The lens immature cataract was seen, which is of grade 3 nuclear sclerosis. Extraocular movements were full and free in all gazes. And coming to fundus examination, in right eye, the media was hazy due to vitreous stance and the focus was at +10 diopters. The optic disc size was small, shape was normal, color pink, margins were well defined. Cup to disc ratio 0.4:1, vessels were normal, A:2:2:3, and general background showing multiple microaneurysms seen in all quadrants, and multiple dot and blot hemorrhages were also seen in all quadrants. Macula in right eye, the foveal reflex was dull with multiple dot and blot hemorrhages. In left eye, the media was hazy due to lenticular sclerosis and central lenticular opacity. The size normal, shape normal, color pink, margins well defined. Cup to disc 0.4:1, vessels were normal, and the arteries to vein ratio is 2:3. General background again showing multiple microaneurysms in all quadrants and multiple dot and blot hemorrhages in all quadrants. Macula, foveal reflex dull. So at this point, our provisional diagnosis was right eye surgical aphakia with moderate non-proliferative diabetic retinopathy, and left eye immature senile cataract of grade 3 nuclear sclerosis with posterior subcapsular cataract with moderate NPDR, non-proliferative diabetic retinopathy. So we went on with the further investigations. We continued with biometry and ocular B scan. The axial length of the eye was 20 on A scan. We could see the absence of lens spike in right eye. And axial length in right eye came to 23.6 mm and left eye 23.17 mm, AC depth 3.38 mm and 3.35 mm in left eye. Eyeball power was calculated with SRK2 formula depending on the axial length. And these are the B scan images. So our plan of action was to go with the surgical approach in both eyes with anterior vitrectomy, pupillary reformation, and secondary IOL implantation in right eye. In left eye, it was phacoemulsification with foldable PCIOL implantation. So because the patient is a driver and he needed an immediate, not an immediate, but a good visual correction first. So we went ahead and corrected his left eye first, which was done on 3rd of July 2025. That is, it's 2 weeks back. And in left eye, phacoemulsification with in the bag implantation of hydrophobic foldable intraocular lens was done. So as planned in right eye, it was operated today morning. So with anterior vitrectomy followed by posterior synechotomy and pupil reformation, a thorough through temporal transconjunctival sclerocorneal tunnel incision of 5.2 mm, a modified retrofixated iris claw lens was implanted vertically at 3 o'clock and 9 o'clock position and enclaved, and the PA was done at 2 o'clock. AC reformation was done with wound hydration. So these are the images of post-op. So right, it was done today. You can see the peripheral iridotomy and the pupillar reconstruction reformation. The POD 15, the vision in left eye is 612, improving to 6.6 with pinhole. The correction is 0.075 spherical with a near rad of plus 2.75 spherical. This is a short video of the surgery. So that's a side port. We noticed synecave extending from spirotemporal to infratemporal, which were broken, and anterior vitrectomy was done. So we are this was a transconjunctival sclerocorneal tunneling, measuring about 5.2 mm. This iris claw lens was inserted, oriented vertically. This is the iris claw holding forceps, and inclination was done. hook is being held to retract the iris to keep the IOL in position. And the peripheral iridotomy was done at 2 o'clock position. And the wound was closed with stromal hydration. Thank you.
Okay.
Yes, over to the examiners for, you can unshare the screen.
Was the patient referred to you, or the patient came on his own to your hospital?
So the patient was actually referred by one of his relatives to our hospital, sir.
Yeah. You must have asked him the detailed history, means what the previous surgeon told him, what means
Sir, actually
during
the
surgery.
patient was actually having complaints for past 1 year. He consulted at a
Okay.
local hospital, and later, when the surgery was done, he got to know
Yeah.
what happened during the surgery, and he consulted other hospitals as well. But
Okay.
due to his poor glycemic control, he was not taken for surgery. So that's
Okay.
what happened with us also. We admitted the patient, and we got the sugars under control, and then we operated him, sir.
What was HbA1c levels? Do you know?
It was 7.2, sir, when he presented to us.
Was he having any renal issues?
No, sir, he did not have any renal issues, sir.
Because he was only taking metformin. So,
So we checked with our lab reports, sir. There was nothing abnormal with his renal function test.
okay.
Shravani, I have one question. Your antechamber depth in
Sir.
both the eyes is almost symmetrical, almost.
Yes, sir.
What do you expect in a case of aphakia?
So aphakic, we
How much
expect the
was it?
chamber to be more deep, sir, compared with the cataractus side. It should be more deep, but
Yeah.
we expect it to be deep, sir.
So how much is it? There was hardly any difference in your case.
Yes, sir. Hardly there was 0.2 mm, around 0.3 mm difference, sir. I mean,
Okay.
it was 3.38 and 3.33.
Sure. Why didn't you use applanation tonometer to check the intraocular pressure?
What is the gold standard?
So it is Goldman's applanation tonometer, sir.
What will happen in a case where there is a vitreous loss and you do a Schiot's tonometry? You will get a pressure which is on a higher side or on a lower side.
So we will get a reading which is on higher side.
No. There is a vitreous loss, scleral rigidity will be affected. So it will be Audsley low. Okay, very well. Good. So this
You
is
have
how
mentioned. Yeah, please go ahead, sir. Please go
No,
ahead.
Deshpande sir, just I was trying to elaborate for that.
No, sorry. I think you have mentioned the pressure as 15, but ऐसे shows में 15 reading नहीं आता है. It is 14, 17.3.
So actually, I took average of 3 readings in Schiot's, sir. It was not 1 reading. I took average, sir. 3 readings I took with Schiot's, and I took an average of those readings. It was not
Why did
1
you
reading.
do that?
To get somewhat accurate value.
Is it painful? Is it harmful? It has side effects, no? Schiot's tonometry.
So there will be corneal.
And then patient will have, there is a risk of infection and corneal injury. Why do you want to check? Why do you want to take average?
Also, do you think if you take 3 readings, do you think with the Schiot's tonometer, what will happen to the second and third reading? Especially
Ma'am,
done
actually,
without too much.
the patient fixation, when I was doing the fixation was not actually coming accurate. The patient was actually looking at a closer objects. I wanted him to look at a farther objects. That was
What
one thing.
happens to the aqueous when you do Schiot's tonometry again and again?
Subsequent readings, madam is asking what will
Subsequent
happen.
readings, do you expect, if you keep doing, do you expect them to be lower subsequently or higher?
They
And
will
why?
become lower.
And why should that? You're right about that. Why? Because it doesn't really make sense to take 3 readings and then take an average of that. Because, the indentation will cause some aqueous to filter out of the angle of the anterior channel. So you will take lower readings.
Actually, the fact is, she has done NCT most of the times, and only once at the presentation and just before surgery, she did shear tonometry, and probably she has taken that 14 and 16, she has taken as 15. And NCT was frequently used in our hospital because of the patient load, ma'am. And preoperatively, we do applanation, but postgraduates, they are little apprehensive for doing applanation, some of them. So probably she has done shears in this patient. But this patient was little uncooperative also, right, all through. But since he's a driver, we have to take care of him. And though his blood sugars were not under control, we have admitted him. We got our physician see him, and he was on insulin before he was operated. And till this morning, we have been postponing the second eye because his sugars were not under control. This morning we could do the second eye, and luckily things went on well, and now he's doing well. And tomorrow we have to see how is the vision in that eye, second eye. And this applanation thing, we do, most of our consultants does applanation, but NCT is what is being practiced for regular OPD. In NCT, we have an NCT in the OP, the general OP. There they do NCT most of the times. Probably this case, she has done shears.
Okay, Dr. Shravani, tell me, what do you think must have been the reason that he was not implanted with the IOL at the primary surgery? Because, nowadays, everywhere in the world, intraocular lens is primarily implanted. The numbers of aphakic patients we see is really dwindling. In our times when we were residents, we used to see a lot of people who were aphakic. But now, you hardly ever see aphakic patients. And maybe because of other reasons, like we were discussing, subluxation or trauma, or sometimes in children, when congenital cataracts are operated, you may see that they are aphakic, but because there's some controversy between primary implantation. But in this gentleman, why do you think primary intraocular lens was not implanted? Since you have taken this case, you have taken the history, you've been working up with this patient. Why do you think primarily the IOL was not implanted, and do you think it is correct?
Ma'am, they should have
What the
actually
felt-
gone with the intraocular lens implantation at the time of the surgery. But I think maybe because the lens was not available, or maybe because the surgeon was.
Nobody would start surgery if an IOL is not available.
I mean, maybe they're not confident about the lack of support for lens implantation.
What did you find during examination, which told you why the lens was not implanted in the phone? Which
Ma'am, we could not see any posterior capsule, the first thing. And
the surgery was complicated.
yes, ma'am, complicated.
You probably lost the whole bag.
Mm.
Could you dilate this patient nicely in the pre-op period for examination? Did you do indirect ophthalmoscopy?
Ma'am, we were not, sorry, the patient pupil was not dilating properly, ma'am. It
That is
was
why
hardly.
you did B-scan.
Yes, ma'am, yes.
That is why
The
you did.
pupil was hardly dilating, not more than 3, it was hardly 3 mm, ma'am.
Did you suspect a dropped nucleus or something?
Yes, so we wanted to rule out any remnant fragments of the lens in the posterior segment. So we went for a B scan.
Suppose there would only have been a big rent and you still had a sulcus. Would you have done a secondary IOL implantation in the sulcus? And if you would you have done it somehow differently?
Ma'am,
What
if it have supposed to plan for a sulcus implantation, I will look for a anterior capsular support at least, ma'am. So that the anterior capsular support can give some stability to the IOL or the haptic, and we can get some optic capture as well, so that it won't get.
Optic capture was the thing I wanted to ask you. Put it
So
in the sulcus with an optic capture. Can you also tell me what sort of an IOL would you like to put in the sulcus?
Ma'am, I would prefer a three-piece IOL, ma'am, rather than a single-piece IOL, because single-piece IOLs are thick. They have a thick haptics, which can cause sharping of the anterior iris, and they are more planar comparative to the three-piece IOL, which have some concavity. So this will prevent the contact with the iris, creating a UGH
What
syndrome.
orientation would you like to put for the haptics? What o'clock position would you like to put if you're putting in the sulcus?
Not sure.
Would you like to put in 3 o'clock, 6 o'clock? Because in the bag, we generally put 3 o'clock, 6 o'clock orientation. We generally don't in the sulcus, because of the long ciliary vessels and nerves. So we'd like to put it anything other than 3 o'clock, 6 o'clock for the haptics. Otherwise, nicely presented examination, but you did not mention during examination that you could not perform an indirect ophthalmoscopy because the pupil
So
was
the
not
poor dilatation of the pupil.
fully dilating, which we were waiting to see, and that is why you went in for a B scan ultrasound. What is the frequency of the probe of a B scan ultrasound?
20 hertz. Ma'am.
Yeah, anything 12 to 20 hertz. Alright. So
Usually it will be 10 to 15 for for retina. UBM will be 20 to 30. Okay, so bigger the frequency, you will come anteriorly.
if with B scan you want to see the anterior segment, do you know of any way you can do with a B scan ultrasound to see the anterior segment more?
We can measure axial length. I'm aware that we can measure the axial.
If you only have a B scan, you want to see more of the anterior segment, because B scan will give you more posterior segment details, right?
Yes, ma'am.
This is an extra question, but I've seen some radiologists doing it.
How do you assess the anterior segment with a B scan probe? That is what madam is asking. Any technique?
You just have some fluid filled
Immersion technique.
Yeah.
Okay, we'll leave that, I think. Yeah.
Deshpande sir, you can go ahead with some questions for Ravindra sir, Deshpande sir.
It's a surprise also that the patient did not have diplopia to begin when he presented to you.
So, ma'am, because the other eye also he was having cataract. I mean, he was having poor vision in the other eye, so that's why he was not able to he was not having any double vision.
Right.
Dr. Ravindra sir, any questions for Shravani?
What was the status of the angle in the trauma eye?
There was no trauma, sir.
Okay, it was a surgical. Okay.
Surgical.
Can you tell me common causes of posterocapsular rent or condition that predispose to capsular rent in cataract surgery?
Sir, we can have a
Yes, Shravani, you can do it.
Sir, age. Elderly patients are predisposed. Diabetic patients are predisposed for posterocapsular rupture and eyes with pseudo-exfoliation syndrome and systemic illnesses like Marfan syndrome.
There's more
high axial length. High axial length.
Damage.
Yes.
I think sir is asking posterior capsular rent, more chances of any type of cataract which causes more
posterior polar cataract.
Okay. I think pupillary size is a very important determinant for, good outcome after cataract surgery. If the pupil is not dilating, then the chances are more of PCR, isn't it?
Yes, sir, because we don't have the view for rexus.
Which surgery was performed? Was it phaco, SICS, or
It
was
was
it?
phaco. It was phaco, sir. It was
No,
phaco.
before. I mean, at other
Before it
the
was an
primary surgery.
Before we could faintly see a superior temporal scar, sir, which was
Sure.
around 5 to 5.5 mm, which was seen on the superior temporal aspect.
I think
Will you
she
give
mentioned
the
3 mm behind, right?
Yes, ma'am. It was 3 mm behind the limbus.
have you prescribed systemic antibiotics for this patient?
Yes, sir. Yes, sir. We did give him fluoroquinolone, sir.
Acha.
Shravani, you also showed a patient had non-proliferative, moderate and non-proliferative
Yes.
diabetic retinopathy. So, along with the cataract, so what would be your line of management? What would be your priority to treat a diabetic retinopathy or cataract first, or what, or
So
simultaneous?
both, we have to treat both, sir. There's no priority here. We have to treat the both. So first, we'll always go with the proper glycemic control of the patient. And one thing we must be sure while doing this surgery in these kind of patients is go for a large optics, large rexes, and post-operatively we can give NSAIDs to minimize the risk of edema, macular edema in these patients. So this is like simultaneous. We can't give a priority to one condition.
No, you should always remember when you have a diabetic retinopathy and a cataract, the retinopathy will take a precedence in treatment. And that's why you should always mention while doing a pre-op evaluation that when you see an NPDR case along with cataract, you should say you have evaluated the posterior segment and there was no treatable lesion at this point of time. Okay, we should have done an OCT to be sure that there is no edema and then we should proceed. So that should be your answer. Hmm?
Yes.
Good, good, good. Any more questions for her? Okay. So wonderful.
Very well
Shravani.
presented.
Very well presented. So Shravani as well as Nikita, hats off to you both. You have done a wonderful job. Means at your age, probably we would have been shying away from ever coming ahead of any examiners, and that too online when everyone is going to view us. Hats off to your means I should say confidence. This new generation is definitely worth emulating even for our generation. So congratulations, you both of you did well, and of course my special thanks to both the mentors, Dr. Reddy as well as Dr. Mehul. So I think it's time for us to say goodbye. We wish you all the best, both of you, Nikita and Shravani, and my sincere most thanks to all the examiners, Dr. Nilima ma'am, Dr. Shrikant, and Dr. Ravindran for this wonderful and finding some time for our postgraduates. Looking forward to your more interactions with our ARC PG teaching program. Let's say bye-bye. Okay.
Thank you, Dr.
Thank
Thank you very
Prashant.
much, sir, Prashant sir, and all the team.
Yes, sir.
Thank you.
I must thank Dr. Prashant sir to give me an opportunity to be.
No. It's our privilege, sir. You are all teachers. We stand wherever we are because of teachers like you who have contributed to our
But
growth.
it's a wonderful initiative, sir, for the postgraduates learning. And,
Thank
Yes,
you.
you are increasing their confidence, sir. Dr. Prashant, really hats off to you also.
No. Thank you, ma'am. It's a team effort. We are trying to boost because this is the area which has been AIS somehow was missing upon. So we wanted to help out our postgraduates the way they are. So be it. Thank you once more for all
Great
the
going,
kind
sir.
words.
All the best.
Bye-bye.
Thank you, sir.
Thank
Bye
you.
bye.
Thank you.
Bye
Good.
Good night, everybody.